Hello, everybody, and welcome to another BTOG podcast. And this time we have a podcast joined with our friends at the National Lung Cancer Audit, or NLCA. And I'm joined by four excellent colleagues who are going to go through all things National Lung Cancer Audit with me. Now, I think in the UK, we are sometimes not very good at recognizing the best things we do. And I do believe that the National Lung Cancer Audit very much is one of the jewels in the crown of what we do. I think it's fair to say that it can be challenging working in NHS at the moment. Times are not always easy, but we do some things superbly in the NHS, and I think we collect data superbly, and I think we use data superbly, and we're very transparent in that data. And I think there's no better example of that than the National Lung Cancer Audit. So it's a brilliant subject to focus on. And we're very proud at BTOG that every year in our annual meeting, we get an update on the National Lung Cancer Annual Report. It's a really important part of what we do. And this podcast is an equally important part to go through what's been shown recently, the importance of that, the impact of that. And what I really hope is at the end of this podcast, you're so engaged and excited by it. You go onto the portal, you look at the data, you look at your trust, and you go and speak to your team about the things you're doing brilliantly, and you slap yourselves on the back for that, but also the areas we could improve and how might we improve that. So joining me, I've got four, as I say, fantastic colleagues, all part of the NLCA setup. We have Doug West, who's a thoracic surgeon in Bristol, and he's the surgical clinical lead. We have John Conibear, who is a clinical oncologist in London, and he's the oncology clinical lead. We have Sarah Cook. She is the National Lung Cancer Audit methodologist, knows all the tricks of the trade, and she's based in the London School of Hygiene Tropical Medicine. And last but not least, we have Lauren Dixon, who is a National Lung Cancer Audit Clinical Fellow. She's doing a PhD in this, based partly at the RCS and partly at the London School of Hygiene and Tropical Medicine. So I'm going to pick on Doug first because he's at the top of my screen. And I'm going to say to Doug, what is National Lung Cancer Audit and why does it matter? Can you give me a two-sentence answer?
Wow, that's hard. The
It
National
is.
Lung Cancer Audit is an analysis of activity and outcomes for all patients, we hope, diagnosed with lung cancer and having it treated in England and Wales.
And John, why does it matter? Top line. I mean, why should we bother doing this? Why don't we just get on with it and not worry about what everyone else is up to?
So I think, Tom, the value is it turns routinely collected NHS data into a national picture of quality, variation, and outcomes. So it's designed to help trusts, cancer alliances, even clinicians understand what they're doing and perhaps how they could do it better.
Yeah. Sarah, I'm going to ask you to pick out one thing in this State of the Nation report. That's the data that just came out at the beginning of the year. One thing in that that stood out for you.
So the thing that stood out the most to me was the change in stage distribution over time. So the increase, particularly in early stage disease, that we've been seeing the higher numbers and the impact that's going to have in long-term survival.
Fantastic. And Lauren, what about you? PhD in the National Lung Cancer Audit, and there can be no higher qualification. What stood out for you in the data that's come out?
Well, it's a time of big change in lung cancer care. There's so many things happening and so many things changing. I suppose one of the big things from me, of my background as a thoracic surgery trainee, is the change in surgical activity. So we're doing so much more surgery than ever before, but also the types of surgery that we're doing. So robotic surgery and lung preserving surgery as well.
Yeah. So we're going to start off on surgery. I'm going to pick on Doug initially. Doug, there's been an increase in early stage diagnosis. There's the obvious reason for that, which is lung cancer screening. Another thing we do really well. I do sometimes worry we don't talk about how good we do some things. How's that increase in early stage diagnosis affecting your surgical practice and that of your colleagues?
Yeah, great question. I think it really is transformational. If you are looking for a job at the moment, become a thoracic surgeon because activity is massively increased. In the NLCA data, we know that from 2020, 15% of patients being resected. Now we're resecting 22% of all cancer diagnoses, and the big thing for us as surgeons is that big bulge of new stage 1 diseases, they all come into surgery. We're hoping that many of them will. About 80% of people who are screen detected. So that creates a lot of work for us, but also a lot of opportunity, because we've got lots of new options now. We know that the majority of people, a big majority, over 80% of people having lung cancer surgery in this country have a minimal access option, either thoracoscopic or increasingly robotic. And there are options in terms of doing sublabor resections that come in with as good survival results for the right patients, up to 10 years. So we can do more, we're doing it better, but we're doing a lot more. And that's our big challenge, is just doing enough surgery to get to everyone who could benefit.
And is it manageable? I mean, I've seen that huge change in the many years I've been a consultant. Are you and your colleagues able to take on that workload, or are there challenges?
Great question. So we're recording this at 10 to 8 in the evening, and for those of you who are listening, you're spared me looking disheveled in my scrubs because I've just finished operating. And that is common. So in Bristol, we're operating 12-hour operating sessions every day. We've got a lot more operating. I know that around the country, my colleagues are operating on planned lists every Saturday, and that's gone on for a while. Oxford, Southampton, around the country. So we really are bulging at the seams trying to get that extra activity in, because that sort of growth in a surgical specialty is really quite unusual. So we're getting there. It could be better. And I would say the one red flag, I think, on our report this year is how long people have to wait for surgery. Yes. I think that tells us that we're not quite as far ahead of the curve as we'd like to be.
And I guess one would expect that as your numbers go up, your challenges go up, delivering timely surgery is a problem. But there's some great things. So what's the significance of the early diagnosis in terms of outcomes for that early stage disease? What has the NLCA shown us?
Well, we know if we can operate on people in stage 1, they're very likely to be alive and well at 5 years and beyond. So it's a massive change. We can operate on people because of what's happening in surgery, or what's happened in surgery. We've now got a good evidence base behind minimal access surgery with the Violet trial. So we know that we can decrease perioperative morbidity, get people home faster and recover faster. So we've got a great option there. At the other end of the scale, just from a surgical perspective, because multimodality therapy is now, we're now doing a lot of neoadjuvant chemoimmunotherapy. We're actually starting to pick up clinically in more advanced disease. Although I think in the NLCA data, I'll come back to that core message, that it's about a huge amount of extra early stage disease that's coming through. That's what's really changing.
We could clone you, but apart from cloning you, what other ways can we improve the surgical services? Is it just we need more surgeons, or are there other approaches?
No, that's a great question. So there is stuff going on. The SAC in cardiothoracic surgery has identified that we need more people through the system. So we've done ST4 entry for a few years now, trying to just speed up that pathway, get some more surgeons on the floor. And then we also just need to work more efficiently, I think, as well. Of course, extra hours and more operating, but it's also about things like enhanced recovery around surgery, which is getting people in the optimal state before they are admitted, doing small operations, lots of local anesthesia, getting the drains out quickly, getting people up on their feet quickly, getting them involved in their care and optimized before we see them, so that we're making the maximum use of that crucial time in theatre and time in hospital. I'm struck by, when we went through the pandemic, we saw that big drop off in surgical numbers that we recovered more slowly than oncology. And I do wonder if that's because we have a bit of we need beds, and we need some critical care beds to operate. And that's a problem.
I was at a European meeting a couple of weeks ago, and what really struck me was how cohesive the UK thoracic oncology community were, how aware we were about our activity, our data, in a way that many other countries didn't. Am I picking up something correct? I mean, it seemed to be we do very well that compared to our European colleagues.
Yeah, I definitely would agree with that. I had a really interesting chat with Pierre-Emmanuel Falcoz, who runs the European Thoracic Database, when he came to our Belfast meeting last month. And they've got some great data, but it's absolutely nowhere near as being as complete as UK data is. And I think that's a really big strength of the NLCA and UK data architecture more widely. That it doesn't matter if you're in a really engaged unit who really love sending the data or a unit that's not. Your data comes in and your experience is analysed and hopefully acted on.
Brilliant. Now, John, we're going to focus on the oncology side of things, obviously much closer to home for you and me. What's the treatment landscape? Has that changed in recent years for lung cancer patients? And what's the National Lung Cancer Audit telling us about that change in landscape?
So, Tom, I think the landscape's changed dramatically. We've moved from, when I started my training, a relatively simple chemotherapy-based model to one that depends now really on molecular testing to identify patients who will benefit from molecular targeted drugs. We've seen the eve and arrival of immunotherapies, increasing multimodality treatments that Doug's alluded to, perioperative care for patients with both chemo and immunotherapy. And so that's good for patients, but it really reinforces the fact that timely diagnosis, pathology, genomics, and capacity are so critical, to keep up with the changes we see in that treatment landscape.
Yeah. Are more people getting systemic anti-cancer therapy? Are we managing to treat more people? Are we treating people better?
So I think the NLCA data seems to show that we seem to have plateaued in the non-small cell lung cancer group. So we seem to have kind of hit this 63 or so % treatment rate, which is unfortunate because we set our standard. The NLCA sets the standard that we'd like to see 70% of patients treated with SAT. For small cell lung cancer, as you know, it's becoming less common in the patient cohorts that we treat. Again, England's just meeting that 70% standard, which is good, but it does seem to have fallen ever so slightly from the previous year. So we're not seeing those rises that perhaps we'd like to see.
And how sure are we that that's an accurate 60-odd %? Because I think most oncologists would say I definitely treat more than 60% of my performance data as 0, 1, stage 4 patients, although NLCA tell us that's not the case. Presumably, if we are not accurately recording performance status in the data, and we'll get on to a minute with Sarah how that data is collected and where it's collected from, if we don't put the right data in, we may be having slightly misleading data out.
You've hit the nail on the head, Tom. It just goes to show how imperative it is as clinicians and as specialist thoracic oncology teams that we do make the effort to enter the data accurately, so that when it comes to the analysis of our national data set, that it reflects what we're doing in hospitals. Because from my experience within my own hospital, you can actually build business cases. You can look for funding for additional resources to help improve your service through demonstration of these gaps, or perhaps lower than we would like to see treatment levels.
Yeah. And there are some inequalities and variable access to systemic treatment. What are those variations? I suspect we all probably know what they're going to be. And how might we reduce that inequality?
So I think, as I alluded to in my first answer, the treatment landscape has become more complex. So I think to reduce inequalities, we need to make sure that all patients really have rapid diagnostics, molecular testing, that there's capacity to deliver those treatments, and that patients are able to reach us, the oncologists and the thoracic teams, as quickly as possible. And so unfortunately, the audit does show that there's inequalities across NHS England and Wales that is leading to variations in the levels of treatment and the qualities of those treatments.
Yeah.
So I think the challenge is not just about effective treatments, it's about making sure that every patient has access to those treatments quickly enough wherever they live.
And I think that kind of fits in with what we want to do in BTOG. We want to try to reach every part of the UK. You don't want to just preach the converted. You want to make sure that you're reaching all aspects. So Sarah, you're clearly the brains behind the operation because you're the methodologist. For people who are sitting in MDT, like I do every week, and I've got a colleague on my right who's filling out the we use the Somerset database, and then miraculously the data appears in, well, a couple of years later, in an NLCA report. Where are you getting your data from? How does it go from what's happening in my MDT to your beautiful report?
Okay, so we get all of our data as the routinely collected national data, but we're not involved in the actual collection part. So we get what's entered at the trust level. And then for England, we get our data from the National Disease Registration Service. So they will be collating all the data that they're getting entered and sending that to us after some of their cleaning and algorithms. And then they'll send us data from various sources. So we'd have for the state of the nation, we have the rapid cancer registration data, and we also link it with hospital episode statistics, admitted patient care data, and with the SAC data set and the radiotherapy treatment data set. And then with
so just to jump in there, so these are all national data sets which are run routinely by the NHS. If I prescribe chemotherapy, whatever I do, that goes into a SAC data set. Whenever John organises some radiotherapy, that's also being picked up. And then hospital episode statistics, again, these are routine data. Is that right? Every hospital, every acute trust is collecting.
Yeah,
and they're
exactly.
pooling it all together, and you guys are using that combination. Is that right?
Exactly, that's right. Yeah. So we don't have any control over the data or how it's collected. So we're dependent on what's entered and then what we get from the National Disease Registration Service.
Yeah. And so the onus is on us when we're doing our MDTs to make sure what goes in there is accurate. If someone doesn't think the performance status is correct or they're guessing, well, that's not terribly helpful. So we've got to make sure that what happens in our MDT is what's recorded.
Tom, I'm going to push back on you there that you put your hand in data and several years later you see it again, because one of the great things that Sarah and Lauren and the team have done is introduce quarterly data based
I apologize
on
unreservedly for awful accusation.
Based on the rapid cancer registration data set. So the big message to your listeners is go online. We've got the data from the last quarter that you did.
That's absolutely right. Absolutely right. And we'll get on that in a minute, and that's absolutely correct. Sarah, what's the strengths and limitations of the data? I mean, the strengths are fairly clear. We want you to pick that up, but what do you see as some of the limitations of what you can produce?
I think the limitations are exactly what we've just been saying, that we depend on what's entered. So if the fields aren't completed, so if performance status doesn't get entered or it's entered incorrectly, there's nothing we can do about that. We can only work with the data we get. So, and the data, because it's being collected for routine purposes, it's not sort of bespoke for the National Lung Cancer Audit. So maybe the people collecting it, like, you're not thinking about how it might be used by us at a later date.
Is there any other country, I think I know the answer to this, is there any other country that collects such a breadth and depth of data so comprehensively? I mean, I've always thought this is fairly unique. There are lots of international data sets of cancer, but they're often very selective. Do we lead the world in this, or do other countries do almost as good a job?
I have to say, I don't know the answer to that.
I mean, I believe that there's, in terms of the breadth of what we do, that I don't think any other country does quite as well. And I think it's really important because it's easy to look at data from select hospitals and say you're doing marvelously, but unless you look at every hospital and every patient in every demographic, you're kidding yourself. How do you look at the variation across regions? How do you break that down, and how are we using that?
Yeah, so we look both at trust level and Cancer Alliance level, and we would, in the State of the Nation, we'd use something like called a funnel plot, where you'd be plotting for the different performance indicators how the trust or Cancer Alliance is doing on that indicator against the volume. So we take into account the number of patients being seen. And then for some of the indicators, we'd also be adjusting for some things about patient case mix, like age and stage, if it's important. And if it's not important, we wouldn't adjust. So we try to make the comparison as fair as possible. So we're taking into account things which might be affecting how different trusts are doing on different indicators.
And I'm going to move on to Lauren. Can you tell me the background to the National Lung Cancer Audit Quality Improvement Initiative? Tell us a little bit about that and how it came to be.
Yes, okay. So the National Lung Cancer Audit is part of NatCan, which is the family of cancer audits, and the Healthcare Quality Improvement Partnership, or HQIP, tasked each of the audits with creating a national level quality improvement project. And as a team, we decided that the best way we could improve care for all patients was by making sure that every single patient that was diagnosed with lung cancer received support from a lung cancer nurse specialist. So that's what we set out to do with our quality improvement project, and that had two parts to it. So firstly, make sure that we have good data on everybody and whether they had contact with a lung cancer nurse specialist, and secondly, make sure that everybody has support from a lung cancer nurse specialist.
Have you succeeded? What progress have you made?
So we're not there yet, and we knew this was quite a big challenge, but we have made significant progress already. So we've been working quite closely with NDRS, and Sarah and Jess, another member of our team from the data side, have been working really close with NDRS to pick out some problems. So one of the issues we had was a lag in the data coming to us. So for our quarterly reports that are published every quarter on our website, we were noticing some delays in the data coming through specifically for lung cancer nurse specialist. So we worked quite closely with NDRS, and now that problem has been solved. And we continue to work with them to identify trusts that have low recording of lung cancer nurse specialists to try to work with them to improve their data completeness.
And if people are listening saying, hang on, I think that's my trust, we have low data completeness, what can trusts do to help to make sure that the data is reflective of what's going on, and also how they can improve their performance?
So that's fantastic if trusts are picking that out. We also do write to trusts and let them know if they're doing particularly well, or if we think that they need to improve that. But if they contact us or contact NDRS, so their local data liaison person, then they can do a sort of more personalised deep dive into that trust, because a lot of the data collection can be quite different in different trusts. So to try and get a unique answer, we have support in place for that.
Brilliant. Now, look, Doug, people are going to be very excited about this. They've been cycling home. They thinking, I've got to go and look at my data. I want to make sure I'm better than the hospital next door. That's what I spend my time doing. And we are, of course, much better than the hospital next door, because that's the Marsden. And of course, we're better than them. How can people access their data? Where do they go? Do you have to be a member of anything? And what does the data look like? We've got this data in the Nation report, but you correctly corrected me about the more frequent updates.
I know that all London surgeons are keen to go online and learn from their colleagues at the hospital next door in a collegiate way. It's dead easy. Go to our website, and you don't have to have a login, and you don't have to be a health professional. You can go online. There's a great online reporting tool, and you can pick out what you want to look at. Do you want to look at a region? Do you want to look at a specific trust? What outcome predictors do you want to look at? It's all there. And then if you're more of a sort of PDF, narrative sort of person, we've got a great, short, easy to read State of the Nation report. It's got some great infographics in it. So it's all there. And I would encourage it. Again, one big message from today: go home and read that data. You'll find it really interesting, I hope.
Absolutely. John, what do you think are the priorities for improving lung cancer care the next couple of years, based on what NLCA is doing?
So I think maintain the progress that we're seeing in early diagnosis. So I think that's key. And then I think it's important to expand the treatment capacity for those patients. So we need to have theatres, we need to have chemotherapy units there to be able to bring those patients in. And then I think it's improving the rapid diagnostics, so molecular testing, diagnostic imaging. So I think those are imperative. And let's not forget that I think it's important that every lung cancer patient have access to a lung cancer nurse specialist, because they are vital in the care pathway.
And Sarah, from your point of view, what does the future directions for National Lung Cancer Audit? Are there different data sets coming in that you're going to be using? Are you refining how things go? Are there going to be any changes in the methodology side of things?
Yeah, I mean, one thing we're excited about is the possibility of being able to link with screening data to know who's coming in through the screening pathway, and we're hoping that that's something that's going to be coming in the next year or two. So I
think that'd be amazing, and I think that tying in to see the whole picture of the lung cancer landscape would be incredible. And last question to you, Lauren: what role do you think National Lung Cancer Audit plays in driving improvements generally across the NHS in your experience?
Well, I think it's vitally important in making sure that advances in lung cancer care are applied to every patient. And I think it's really useful in working out where care is delivered excellently and where care could be improved. And it kind of tries to even the playing field in that sense.
Yeah, I think absolutely. I think there has been a transformation in how we treat lung cancer. I think we are a very different landscape to how it was many years ago. And we have lots of areas where we excel, thoracic surgery and screening, among others. And I think the National Lung Cancer Audit has been an absolute driver behind that. And at BTOG, we're very proud of our association with you guys, and we are very grateful for all your work. So there you go, everyone. You now know how to get hold of the data. If you're not busy logging on to the portal now, then that's very poor behavior. Please do that and then download it and then go to speak to your MDTs about it and discuss it, because it's amazing what you learn. And we can only improve services if we know what we do well and what we maybe do less well. So I'd like to thank very much Doug, John, Sarah, and Lauren for joining me. Thank you all very much for listening. And don't forget to join us for our next webinar. Thank you very much.